we're invited Brendan Visser to our faculty, and Brendan is a pancreatic, upper GI, and liver surgeon. So Brendan, thank you for coming to speak.
It's really a privilege to be here, and I see a lot of patients that I know, actually, and I know many of you have traveled quite a ways to come and be here today. So, neuroendocrine liver metastases. First I'm talking about liver resection, and then I'm going to talk a little about transplantation. These are some pictures of the liver from different angles. The liver, not everybody has a sense for it, but it is about the size of a loaf of bread, but sort of vaguely triangular shaped and hidden under your right ribs. So why is this relevant? So the liver is the most common site of metastases from neuroendocrine tumors, and most patients develop metastases during the course of their disease in the liver. And the liver disease really dictates the outcome of in the vast majority of patients, and so it's really central in that sense. For those that have hormone-producing tumors, whether that's carcinoid or gastrinomas, the liver disease is the site that allows those hormones then to go on to the systemic circulation and causes many of the symptoms. And surgical therapy, of course, I'm a surgeon, but surgical therapy offers the best chance at durable survival. But I want to admit here, so let me back up one slide. So this is a picture of somebody's liver looking at somebody at the front, and these are some bulky neuroendocrine metastases. And that's this little bit of normal liver over there, but that patient ultimately was resectable despite those bulky tumors. These are few, though large metastases, and that's very favorable for being able to actually remove those. I should add that patient I resected about 3 years ago. That patient is not in the room, so that's good, and is doing quite well, though. So there's reason for great optimism, despite what is a daunting-looking scan at the outset. But I will also say that in many patients, unfortunately, the neuroendocrine metastases are multifocal right at the outset. And this is another patient with very diffuse disease. So all the little brighter areas here are actually areas of metastases. And this little bit of darker liver that you see in the middle is the actual liver parenchyma. And the liver is almost filled with metastases. And very surprisingly, patients can present with very extensive liver disease with a liver that looks like this and shockingly few symptoms. And in fact, when you see a patient who has a liver that looks like this, even in the absence of a biopsy, as people who treat this disease frequently, we know before the biopsy that this is a neuroendocrine tumor, because you can't walk around with any other tumor in this disease burden and walk in off the street. So, unfortunately, because many patients present with more advanced tumors like this, about a small fraction, so somewhere around a quarter of patients are candidates for resection at presentation. So the goals of surgery are obvious. One is to improve survival, long-term survival, and the other is to palliate symptoms. And symptoms can be related to the size or burden of disease, or can be related to those hormones. So the evidence in favor of resection is difficult to interpret, and I'll show you how, as medical professionals, we try to sort of look at the data that supports what we do. But because of the rarity of these tumors and the biologic heterogeneity, no two neuroendocrine tumors behave the same way, there are no prospective trials. Unlike many diseases that doctors treat, we have no prospective trials where half the patients got surgery and half the patients got no surgery. And in fact, really, there's no case-controlled studies and there's no cohort studies, sort of the lesser brethren of randomized trials. And so we really have to go all the way down in the hierarchy of quality of evidence to just case series, meaning various institutions report their experience with liver resections for neuroendocrine metastases over a number of years and tell you what happened. And they just take all comers, some of them they could operate on, some they couldn't, and they tell you what the outcome was. And in fact, so no randomized trial will ever be feasible with this disease because of the rarity and the biologic heterogeneity. But this is what the data, such as it is, looks like. So this is a number of different authors over a number of years, and this is the sort of numbers that people publish in terms of the number of liver resections that they're doing. This is the biggest series, and so you'd say, well, they do an awful lot there. Maybe it would be worth seeing what they do. This is the Mayo Clinic, and in fact, is from 1970 to nearly the present. And so in all of those years, this is how many cases they did. And 1970 is really ancient history in terms of medical therapy. So it's really hard to know how you interpret all those patients as a single grab bag. But with this limited data, the truth is, if you look at the patients that are able to be resected, have very good long-term survival. And that's really what we're looking at, is that in those patients who can get resected, we have expectations that we can control this disease for very extended periods of time that will be measured in years. And anything that's measured in years for those of us who work in the cancer center is a good thing. And the vast majority of patients who are candidates for liver resection get dramatic symptom relief for those that have symptoms related to size or hormone production. So this is then, to look at it a little closer, this is an example of a single manuscript, and this one happens to be from Wisconsin. And so they are looking at their small series, as we all do on an ongoing basis, and they compare the patients who were not candidates for surgery, who they refer to as non-aggressive, which really actually means not that the doctors or patients didn't want aggressive therapy, but that they had a disease that was not amenable, for the most part, to more aggressive therapy, versus surgery, versus those that got transarterial chemoembolization, which is a hepatic artery therapy that we're going to talk about later on. And if you look at these patients, those that were not candidates and got, quote, non-aggressive therapy, didn't do so well, and only a quarter were alive at 5 years. If you could resect it, the majority were alive, and if you got intraarterial therapy, right exactly in the middle. So their conclusion, these data suggest that aggressive management improves survival, but they admit up front it suggests. And we have to always keep in mind that we have to constantly reevaluate our data and make sure that we always are doing the right thing. Just a couple of slides. What does liver surgery look like? So this is traditional open liver surgery, and this is the incision that it requires. So it's a significant incision, it's a significant undertaking. A couple people in the room bear a very similar scar, actually. And it takes typically somewhere between 3 and 5 hours of surgery for average open liver resections, and patients spend about a week in the hospital. And after 4 or 6 weeks, they can probably get back to an office type of job. So it's a significant recovery. Laparoscopic liver resection is also feasible in some patients, and that takes longer to do the operation with chopsticks, but it means that the patients spend a lot less time in the hospital and can get back to work much more quickly because the incisions are much smaller. If you are learning or thinking about liver surgery, truthfully, neuroendocrine tumors, laparoscopic resections are feasible in fewer patients than they are in some other sorts of metastases or primary liver cancers. Because many patients present with bulky disease, like that first slide I showed you, where the tumors are very sizable, or with multifocal disease, such that there's just so much surgery that needs to be done, and trying to do it with chopsticks will just take too long or be too dangerous. So what do we conclude about resection? Truthfully, even when complete resection is performed, early recurrence is common. I think liver resection offers some degree of control for a great number of patients, but it offers a cure for very few patients. But again, that control of disease, turning an acute disease into a chronic disease measured in many number of years, is favorable, and we believe it improves long-term survival. And long-term survival is certainly achievable. Symptom improvement is achieved in most patients. So with that, I think we all agree that most patients who have disease that is resectable should undergo resection. I would also say that for some patients who have functional tumors and are suffering from the effects of those hormones, even in the absence of complete resection, we will look to surgical remedies to help control those symptoms if octreotide and other symptomatic management is failing us. An adjunct to surgery that some of you may know about is radiofrequency ablation. Radiofrequency ablation is also a strategy to try to control the liver disease specifically, and it can provide local control and symptom relief in a group of patients. It is not as good as resection, but is certainly second best to resection. It can be done laparoscopically. Sometimes it's done at open surgery, and sometimes it can be done percutaneously, meaning a CT scan can guide the needle through the abdominal wall and into the tumor. And this is what RFA looks like. The needle is guided into the tumor. In this case, this is radiofrequency ablation. There's also microwave ablation and other technology. These little tines come out into the tumor, and you burn the tumor and a ball of liver around it. This is a picture of what it looks like on a CAT scan. Here's the actual needle. So the radiologist gets CAT scans as they advance it, and another CAT scan as they get closer and closer to the tumor, and then they burn it. This is a picture of what it looks like to do laparoscopically. A little hard to see. But here I'm guiding the needle in, and I'm just looking at it with a camera, and I use ultrasound to make sure I'm in the middle of a tumor. So there's a number of institutions that publish their experience with radiofrequency ablation for neuroendocrine tumors. Most patients require a number of therapies, and they are burning between 3 and 10 separate tumors to be able to achieve some degree of local control and symptom relief. But a good number of patients get symptom relief. Essentially, all patients ultimately have progression, because this is not a really definitive therapy, but is one of just achieving local control for a period of time. And truthfully, even the data for this in terms of its impact on survival is really entirely muddy. And it probably, I think we can extrapolate from surgical data that it can, in some patients, likely help achieve survival, but we don't know that in any meaningful way. So this, I think, is also a really important question that comes up very frequently because it's muddy waters. So I'll talk about liver transplantation as well, which is, of course, the most radical surgical resection for liver metastases. So I'm going to give this big caveat that I'm not a transplant surgeon, though I was trained in transplant, so that's the next best thing. But I don't do transplant on an ongoing basis. So this is the most radical surgical resection, right? You take out the whole darn liver. Nonetheless, recurrence is still nearly universal. Again, this is a disease control strategy. It is not a curative strategy, despite the radical nature of liver transplantation. And the thing about how medicine as a whole, and doctors who do transplant, but also doctors who don't, think about transplantation is unlike other therapies that can be applied to any number of patients who present with a disease. Transplantation cannot, because it is a limited resource. So quite distinctly from the every other therapy that you'll hear about today, when physicians try to judge the role of transplantation for neuroendocrine tumors, they are measuring survival not against any other therapies for neuroendocrine tumors, but they are measuring survival against other indications for transplantation. Cirrhosis related to hepatitis, other tumors that require transplantation, biliary cirrhosis, the great number of diseases which require transplantation. And so that is the yardstick by which transplantation for neuroendocrine tumors is measured, and hence the decisions about allocations of this limited resource are made on that basis. So that makes it quite distinct. So transplantation is done, okay, and the baseline rules about transplantation for neuroendocrine tumors. The primary has to be resected. You have to have liver-only disease, okay? It is important, in order to get consideration for transplantation, that the pathology and the patient have a favorable natural history in biology. Lower Ki-67 indices, a more favorable natural history from the onset of resection of the primary, whether that's pancreas or carcinoid, to presentation and progression of metastases. Those are important in the consideration for transplantation. In essentially almost all other cases, some other means to try to control the liver disease has been done and failed, and often more than one of these. Resection and then TACE, resection, ablation, TACE, TACE, resection, ablation, in some combination, almost always are performed. That is to say that in these cases, like most patients, it has to be believed that the patient would ultimately succumb to their liver disease in the absence of a transplantation. So does it work? So again, similar sort of data from a number of institutions. The numbers of patients that get transplantation are smaller. This is the European Liver Transplant Registry. So this is all patients in all of Europe up to 2007 who had gotten transplantations for neuroendocrine tumors. All patients in all of Europe up to 2007 was 120 patients. Okay, So here's the survival. The 1-year survival is quite good, which means patients don't die from the liver transplantation or shortly afterwards. And then the 5-year survival is here, so ranging between 40 and 80%, which is actually awfully close to the other modalities that we've been talking about. It is not a panacea. On the other hand, these are patients that were not amenable to those other therapies because they had more diffuse advanced liver disease, and yet they have pretty good survival in this setting. So how does it work in the United States? So it is a case-by-case consideration. The organization that runs transplantation in America is called UNOS, the United Network of Organ Sharing, and their policy and their bylaws, and if you look at the allocation system for liver transplantation, neuroendocrine tumors are not mentioned. That word is not in there if you search for it. Okay. However, there are, quote, exceptional cases, and neuroendocrine tumors can be considered under that heading of exceptional cases. Neuroendocrine tumors are not given any priority, though, for points. You may know that, for example, primary liver cancer or hepatocellular carcinoma actually gets bumped up. They are given, there's a point system based on the severity of the liver disease, and those patients are given extra credit points, in essence, to bump them up the list for those with primary liver cancer. Neuroendocrine tumors do not receive those points as a rule. So what happens is a case can be brought by a single institution to their UNOS regional board, and this is a map of the UNOS regions. We're region 5 right here. And the regional review board can, at their discretion, give patients extra points. And very often, if they see a neuroendocrine tumor, they would, if they decided it was a good candidate, give the patient the same number of points that they would get if it were a hepatocellular carcinoma. But it is purely at their discretion, and they can actually give fewer or more points at their discretion, which sounds a little arbitrary, but it is part of this case-by-case review where they're trying to choose patients who will do most favorably. And so then the transplant priority depends a great deal on the region. And I think this is important in light of media exposure that those rare cases of transplantation, when it occurs, get. It has a lot to do with where you are, in fact, which is also somewhat arbitrary and unfair, but it is important to know. So how about closer to home? And these are real numbers that are actually as of when I made these slides last weekend. So these are the patients currently listed in the Bay Area alone, among 3 institutions in the Bay Area that do transplantation in Region 5, which is one of the busiest regions. So as of last week at Stanford, we had 454 patients listed. CPMC had 490, and UCSF had 746 patients listed for transplantation, just within a stone's throw of where we are today. That's an awful lot of patients. And our Region 5 waiting times, and this is the latest data available through UNOS themselves, our Region 5 waiting times are a little daunting. 1,600 days for a liver. So it is not that liver transplantation is not possible and not allowed, but the logistics of this and the waiting time and the listing aspects really mean it is actually out of reach for most patients. And the truth is, the things, it's quite similar in Europe, where they're a little bit more amenable to bending the rules. Because I trained in Europe, I got these from a friend of mine who's a European transplant surgeon. And so this is the very latest data from the European Liver Transplant Registry up to 2009. And so this is the indications for transplantation. 14% of transplants are done for cancer in Europe, so that doesn't sound bad. But these are the cancers. Here's HCC in yellow, and HCC is growing, growing, growing. Metastatic cancer, which would include a variety of sort of odd tumors, but for the most part neuroendocrine tumors, is this little red line, and this little red line is getting narrower and narrower over time as the incidence of hepatocellular carcinoma increases, and it becomes a growing problem in both in the United States and in Europe. And the enthusiasm in transplanting neuroendocrine metastases has waned to some degree. And again, it's because what they're doing is they're comparing transplant for cirrhosis and other indications to those for cancers. And even this includes hepatocellular carcinoma, which overall has a slightly more favorable profile compared to neuroendocrine metastases. but these two lines still remain divergent. And so cancers don't do as well as other indications for transplant. So organs are ultimately still going to other indications for liver failure rather than for cancer. So conclusions. Given the prolonged survival, resection is really the standard if it is possible, if it is achievable. And debulking and RFA can be used in selected patients with symptoms. But while transplantation is feasible, it is feasible in, unfortunately, very few cases still.
Thank you.
Auto transplant. Well, so there's a few ways to use that, but I suppose what that's probably implying is in some very extensive cases of liver disease, one can remove a liver, do a resection, and transplant your own liver. There's a number of ways that liver transplant can be achieved. They're cadaveric. The vast majority of transplants in the United States are cadaveric, meaning they come from a person who is recently deceased or is declared brain dead. There can be living-related transplants where a family member gives up a portion of a liver, and the rules for that are different. And in fact, there are not too many rules for that, with the exception of having a healthy donor and somebody who will achieve a good outcome. But because there are two people who are put at great risk from a big operation, and you can potentially have from a single cancer therapy 200% mortality, that is approached very gingerly. And then there are other things that can be done when you are pushing the envelope. And for example, there are back table resections where there's so much tumor in the liver that you can't actually take out the cancer in situ. And so, but you could remove the meaning while it is in the body. But you could actually take the liver out, and when it's on sort of a back table and it's in a perfectly controlled scenario and there's no blood going through the liver, could remove the tumor and then put your liver back in. And there are sort of variations in between.
So I think, the question is Stanford doing auto transplant of the liver?
What did you say?
Yeah.
Right. The answer is no. We push the envelope, but the number of auto transplants that are reported worldwide in that sense, you could count on a couple of hands. It's not common.
Can you talk a little bit about some of the double liver resections that are occurring and explain the way the regenerative process of the liver works? So there are surgeries.
Yeah. So the liver is a remarkable organ, and the reason why this works, and I could show you that slide where it looks like the whole darn liver is tumor and there's this little island of liver out there, is the liver, unlike any other organ, regenerates. And so for a healthy liver, about 20% of the liver can be left behind, 25%, and that 20 or 25% will actually grow back in the course of actually a few weeks, something like 6 weeks, and be the size, not the shape, but the size of the liver at the outset. So in some cases, for example, if I have a patient who has very extensive disease, I cannot at the outset, when I look at the scan, come up with a way to carve out all the tumor that will leave that sort of threshold 20 or 25% safe margin where you won't have liver failure. But if there's extensive disease on the right side and the left side, I sometimes can start on the left side, clear the left side of tumor, and then very often what I have to do is alter the blood flow to the liver to encourage that left side that is tumor-free to grow, and while the right side that still has tumor in situ atrophies, and then come back in 6-8 weeks, in that kind of time frame, when that growth has occurred, and then be able to go back and get the rest of the tumor. So it means that you can really push the envelope of what can be done, and this is actually that two-stage resection we do very commonly at Stanford. But it's a significant undertaking. It means 2 big liver operations. It's not trivial, but it can mean that we can make things resectable that were previously unresectable.
Thank you. After a patient has a surgery like this, or really any liver surgery, how does sort of the function of that liver compare to the function of the liver before cancer developed in the liver?
Remarkably the same. So despite having what looks like a little bit of liver that grows, that liver then can go on to work exactly as your native liver, such that you can eat all the same foods, you would metabolize medicines, including chemotherapy, in the same way, and in fact, unlike even, say, a bowel resection where the plumbing is permanently altered, and so people can have very long-term slight differences in adaptation, the liver can grow back and act as your native liver was undisturbed.